Good afternoon, colleagues. It is exactly 12 noon on the dot, and I see we have about 12 attendees who have joined us currently. Just to welcome everyone in attendance to our monthly webinar for the month of July. And today's webinar is titled The TB Investment Case, Preliminary Outputs. And with that said, I think I can hand over to my colleague, Dr. Jody Boffa, who will help us introduce the speakers for today's session. Over to you, Jody.
Good afternoon, everyone, and welcome to this edition of the TB Think Tank webinar. We'll be hearing from 3 speakers today. Dr. Gesine Meyer-Rath is an MD, PhD health economist working on the economics of infectious disease interventions in low and middle income settings. She's a research associate professor in the Department for Global Health at Boston University in the US, and a principal researcher at HERO, the Health Economics and Epidemiology Research Office at Wits University. Her focus lies on modeling methods for economic evaluation and translating research into recommendations for public policy, in particular for HIV, TB, and COVID-19 programs in South Africa. Lisa Jamieson is a biostatistician, infectious disease modeler, and health economist based at HERO since 2015 and in HIV and TB research since 2006. She has a Master's of Science degree in statistics and is currently completing her PhD in health economics at the University of Amsterdam. And Dr. Mamapudi Kubjani is an epidemiologist and modeler interested in modeling TB and population-level impacts of interventions. She recently completed her PhD at the University of Cape Town, which focused on modeling TB in South Africa and contributed to developing the Tembisa TB model. She is currently working at HERO. Thank you so much, and we'll head over to our first presenter, Dr. Meyer-Rath. Is she on the line? Okay, I see that our presenter is having trouble unmuting herself.
No, I've unmuted now. Thanks. Good morning. My name is Gesine Meyer-Rath. Apologies for not being able to share my video this morning. Could someone bring up the slides, or should I share them?
I think you better go ahead and share them.
Okay. Give me a moment.
Gesine, we have the presentation up if you're able to see it.
Yeah, perfect. Thank you very much.
Okay.
I think that works much better as my connection is unstable. Could you put it into a presenter mode?
Yes.
The full screen?
Jody,
Thank you
please.
very much. Good morning. So while this is coming up,
is it? Let me know when it's in presenter screen, because I had it in presenter screen. Apologies, everyone.
We need the full screen rather.
Is it coming up now? Because I've got it as full screen.
Not yet.
Just
Not yet.
click on the enable editing on the top.
I've got it. Oh, okay. Are we okay now?
Now the screen share has stopped. Apologies, everybody. Julie, could you share again?
Yes, trying now.
Okay, perfect. Okay, thank you very much, Jody, for the kind introduction. Next slide.
Sorry, I'm trying to figure out how to mute myself.
Okay, just by way of background, this is an update to a presentation I gave about 1.5 years ago at one of the early TB think tank meetings that was convened to help with the strategic planning for the National TB Program. And you might remember that we talked about our plans to do a new TB investment case at that stage. What we're doing today is to show you the preliminary results of our first run of the TB investment case. Preliminary because we are still refining it, but also to give you the results that basically went into not only the the strategic plan for the National TB Program, but also into the TB chapter of the National Strategic Plan for HIV, TB, and STIs. I'm sorry, I'm struggling to see the screen because there's still a drop-down menu. Thanks. So by way of background, TB funding in South Africa is slightly different from those of us who work in the HIV space, in that most of the funding doesn't come from a ring-fenced conditional grant issued by the National Department of Health, but most of it really comes through provinces' general health budget called the equitable share. And the conditional grant, which is now in fact renamed as the District Health Grant, but used to be the HIV, TB, Malaria and Community Services Conditional Grant, only covers MDR-TB hospitals directly, as well as bedaquiline and expert tests. So really only 3 very specific budget lines, which complicates budget planning and expenditure tracking, in as much as that we can't directly track what provinces spend on TB out of their equitable share. Next. However, we right now know a lot more about TB expenditure than we did at any time in the past. Virtually for the first time, we have done a very detailed expenditure review as part of the National AIDS Spending Assessment Plus, NASA Plus, which looked at the expenditure for HIV as well as TB from all sources in South Africa for the financial years 2017-18 to 2019-20. So 3 years, and you can imagine it took about a year and a large team of analysts to find this expenditure across all sources. So not just the Department of Health at all levels, but also the Department of Basic Education, Social Development, etc., as well as the funding from international donors such as the Global Fund and PEPFAR, but also from individual NGOs, the private sector, embassies, etc., etc. So what this big exercise showed, and unfortunately it's now about 3 financial years out, but it's still fairly recent, what it showed that the total expenditure from all sources was 4.4 billion rand in financial year 2019-20. Exactly 2/3 of this was publicly funded. About half of it, of the total expenditure, came from, in fact, the general health budget, so the equitable share that we just talked about. A little bit less than 2/3, so 60% was spent on treatment alone. And within that treatment tranche, again, 2/3 were spent on DRTB rather than drug susceptible TB. Out of the total, 18% was spent on screening and 3% on prevention. And that is also, I mean, coming to think of it, you'll find the same in our results, that prevention are very few interventions. It's mostly really ITP at this stage. So even though this looks almost like an inequitable distribution between treatment and prevention, some of it is also warranted by the fact that we do not have a lot of prevention interventions available to us for TB at the moment. Out of the total, again, a bit more than 1/3 was of all expenditure was on staff, 23% on medical products and supplies, and the rest mostly on drugs. Next. So the question is, why do we need an investment case for TB in particular? In the way we understand them, investment cases are analyses that calculate the best mix of interventions against a specific issue over as many years as it takes. And that is quite different from other types. So, for example, a business case that we look at what an investment upfront would yield in terms of benefits or returns over very many years. And that is, of course, that long take is, of course, really important in an infectious disease where most of the benefit will not lie, or some of the benefit, of course, lies in the immediate impact on mortality and morbidity of the people treated or prevented from acquiring a disease. But the big benefit is really in the prevention of onward transmission over many years, decades into the future, and then looking at it from a population level. It can incorporate the future outcomes of short-term investments, and as such are often different, those investment cases from cost effectiveness analysis, which often only looks at a single intervention. An investment case that allows the consideration of all interventions at the same time then allows for what we call allocative efficiency optimization. Now that's a very big term, but basically means allocative efficiency is the way in which we allocate a given amount of money, in this case the TB budget, across different options of spending this money in a way that maximizes an outcome. And we can look here at any outcome. In our case, we choose TB cases and survival simply measured in life years saved. So we don't have QALYs and DALYs, if any of us are interested in those, which are basically a combination of survival and some idea of the utility of those additional life years. Here we simply look at survival, life years saved, as well as TB cases. Next. This entire project, so both the expansion of the Tembisa TB model as well as the investment case work, has been funded under a single project called Project Linganisa, which is Zulu for weighing, measuring, calculating. It's a project funded by the Bill and Melinda Gates Foundation. We're in its last year. We are hoping for an extension for another 3 years from next year onwards. The principal investigator is Lee Johnson at UCT, the main developer of the Tembisa TB as well as HIV models. And it is the first time that we have one grant that allows us to combine EPI estimates and economic analyses and budgets for HIV and TB in South Africa. We started with a year of stakeholder engagements, and that gave us an idea of which interventions to focus on and to add. There was a special request to include new TB screening strategies, including digital chest X-ray and TUTT for a number of different populations, as well as active TB case finding and IPT for individuals previously treated for TB. Next. So how does an investment case fit into the health decision-making, planning, budgeting continuum? Now, if you think of the whole that whole continuum as a bit of a cycle, then we start with the Tembisa model estimates next, as well as cost estimates that we generate either at HERO or extract from the literature. And we did a very comprehensive literature review just for this TB investment case. Next. Both together then give rise to estimates of cost effectiveness, which in turn, through the investment case, give rise to a set next of optimized interventions and targets. And that's really important that we use this type of outputs, not just to say where to put the money, but also how far to take each intervention, which is really important for the strategic plans. Our main outputs there were not only the costs and the budgets that were required to go with them, but also really the targets for each intervention. Next. This then gives rise to policy and guidelines. And Jody, sorry, who's driving the slides, you can bring up the next boxes quite quickly now, which in turn informs national plans, including the national strategic plan, the national budget, and then continue, sorry for this, the provincial budgets and provincial implementation plans. We have a side exercise where we are looking at the execution of this budget at the provincial level, which then in turn informs next exactly how much and how well these interventions have been implemented. And then that lastly informs updated service statistics, next, which in turn are used to update our Tembisa model estimates of baseline coverage. So you can see this is cyclical. It also works to run roughly once a year and allows us to have most of those activities, estimates and budgets all from the same set of underlying assumptions, for better or worse. The investment case is really what's happening on the right-hand side. Yeah, next. So as said, we used the Tembisa TB model as well as our own estimates of the average cost of a number of existing and novel TB interventions, including adherence interventions and enablers. And this was based on a literature review that we undertook, as well as our own cost analyses of recently trialed interventions, for which we worked with a great number of partners to review the most recent cost, in particular of pilot programs, which we then additionally updated to represent a more routine type implementation of those interventions. We use this to produce the total cost as well as the total budget required for the National Strategic Plan and the NTP Strategic Plan, as well as the incremental cost effectiveness of each intervention at different coverage levels over the baseline of the existing TB program. We have two scenarios, and I won't go into these any more detail because Pudi will set us up much better when it comes to them. Thank you very much. Over to you, Pudi.
Okay, hello everyone. As mentioned, I'll go through the methods that we use to conduct this analysis. Oh, next slide. Okay, so this slide should give you an overview of the underlying epidemiological model that we use to estimate the TB epidemic indicators and also the impact of interventions. So this is the Tembisa transmission model, TB transmission model, which was integrated into the existing HIV model. The model is informed by various data sources from demographic data and epidemiological studies and systematic reviews to inform the model parameters. We model transmission and using studies from South African surveys on social mixing patterns to model transmission, and we also include a simplified care cascade pathway where we track people from having TB, having symptoms indicated by smear status and HIV status and by sex, which determines the rates of health attendance. We also include the proportion that eventually gets diagnosed and initiate treatment, and we also consider various treatment outcomes. To ensure that the model is consistent with observed TB data from South Africa, we calibrated it using a Bayesian calibration approach to the various data, including treatment initiations from the ETR-SEN and deaths from the vital register and microbiological tests from the National Health Laboratory Services, and also our 2018 TB prevalence survey. Next. Yes, as I briefly mentioned earlier, so the Tembisa TB transmission model is integrated within the existing HIV model, and the population, the South African population and the epidemics are simulated dynamically from 1985 to date and projected into the future. And the specific strata or population subgroups that are mostly important for the TB modeling include age and sex, which are the demographic variables, and the HIV-related strata, which allows us to estimate the impact of HIV on TB, includes testing, HIV testing, history, status, and also CD4 count level, ART status, and duration on ART. And the TB states that we have considered are as shown in the figure on the right. Yes, you can go next. As you may have seen, so in the previous slide and previously, the model has implicitly been modeled in considering drug susceptible TB, And more recently, Lee Johnson has worked on adding drug-resistant TB states, and essentially the addition were additional 4 states for treatment or for untreated drug resistance by SMERS status, and also drug-resistant treatment on first and second line drugs. And this to ensure that these estimates are consistent with our South African BRTB data, the model has been calibrated to the prevalence surveys that have been conducted in South Africa. So the one in 2001 and 2002, and the one from 2012 and 2014. And I think there was another one from 1980, earlier back then in 1986. And it's also been calibrated to refer the number of diagnoses. The data is obtained from the National Health Laboratory Services, and also to the number of patients who are starting treatment. These data initially were from the WHO system, but recently we have managed to get the raw data from the NHLS, or from the EDR, sorry. And the years that we include were 2007 to 2020. We can go next. Okay, so this figure shows the model calibration to the prevalence survey data, in blue for men and red for women. As we could see, the model did fairly well in representing the observed TB prevalence, but slightly underestimating for females. And what's also clear is that the rates of TB or TB prevalence is much higher in men than female. Next. Similarly, the TB mortality trends are much higher in men than female, and the model did fairly well in fitting the data, but slightly overestimating for the much later years. Next. And these are the calibration figures for the DRTB data. As we can see for the prevalence, the model fitted the data fairly well, but slightly overestimating the later years for the 2014. And for the number of diagnoses and the treatment initiations, the model fitted the data fairly well in the much later years. Next. Okay, so now coming into how we estimated the TB program cost. So as mentioned earlier, we use the Tembisa TB model to generate target populations. So these are the populations that we target to meet, or the number of people or the level we would want the interventions to reach. And the level at which we set these were informed by the National TB Program and Strategic Plan stakeholders, and the National Strategic Plan stakeholders, and the TB Think Tank Secretariat. And we also use the average unit cost of each intervention. These were informed by the recently updated National TB Cost Model from HERO, and this is informed by literature reviews and trials and work, including own estimations. And to estimate the total cost, essentially, we use the average unit cost, the average cost of the intervention, and the product of the average service cost and the target populations. And to bear in mind is that all of the costs were from a provider perspective, and they are based on 2021, 2022 South African rents and are undiscounted. Can go. Okay, so in these next slides, we'll be describing the interventions and the populations that we are targeting to model their impact. So for prevention, we're looking at IPT and 3HP for people with HIV and for people for household TB contacts. And the population that we model is the number of treatment of TBT initiations. For screening, we're looking at the general public health, for those who are visiting general public health facilities in people with HIV, and for household contacts, and also looking at door-to-door screening. And for the first three, in the units that we're looking at is number of screening, which is to bear in mind, whereas for the others, it's the number of screens that are performed. You can go to the next. And under screening, we also have mobile digital chest X-ray, which is implemented within a context of the door-to-door screening. So after following a door-to-door symptom screen, if someone tests negative or is asymptomatic, they will get a digital chest X-ray, and if they test positive on a digital chest X-ray, they will get an expert test. And under the testing intervention, we have expert and culture, which are part of the current existing program. And other testing interventions are the targeted universal testing for people with HIV, previous TB, and or household contacts. And we also have the linking to patients to treatment, indicated as initial loss to follow-up. Next. Okay, so in this next slide, we'll show the average cost of the interventions. So for the prevention, we have IPT and 3HP, but 3HP slightly more expensive, although it's taken for 3 months and IPT for assumed to be for 6 months. And the screening intervention, mobile chest X-ray, which being the more expensive one, and then the testing intervention having culture and experts, as you can see, and we can go to the next. And under testing as well, we have the targeted universal testing, which are slightly more expensive than experts, costing around 300. And for the treatment, for drug susceptible TB, we are considering for outpatient and inpatient separately. And for DRTB, we are considering the combined costs, which includes both inpatient and outpatient, and being the most expensive treatment around compared to the other treatments, and also have treatment for children. Next. Okay, so now I'm just giving an overview of the scenarios that we have modeled, so that when the results are presented, it will be much clearer. So we have the baseline scenario. This is the current trajectory of the TB epidemic and the current TB program interventions with no changes. And then we have the NSP scenario, where we have all the coverage levels as informed by the NSP and TP stakeholders. And then we have the MAX 1 and MAX 2 scenarios, which we defined ourselves, and in efforts to aggressively reduce TB incidence and mortality in trying to meet the NTB targets. Okay, next slide. Okay, so under the NSP scenario, so these are deemed to be feasible by the stakeholders. So under prevention, the populations that we are targeting to meet, for instance, for prevention, we're reaching around 300,000 people to be initiated on TPT, and for screening, what is important to remember again is that the units are number of screenings. So and under door-to-door, which are the newer interventions, through the target is to reach around 5 million, and digital chest X-ray about 400,000. And for the testing interventions, the TUTTs, for the household contacts and for PLH, for previous TB, the populations we're targeting around 300 to 400,000, whereas for PLHIV, the population that we are reaching is about 3 million, and this will have implications on costs later on. And the testing that is also part of the current interventions experts, reaching around 3 million per year, and culture at about 700,000, and to reduce initial loss to follow-up to about 7%. Okay, so this is an overview of the first MEX scenario that we defined. We in these scenarios, we were trying to scale up a lot of the screening interventions, as in preliminary exercises, these were the most impactful over time. So in this scenario, we maxed out the door-to-door screening, reaching adult South Africans 4 times a year, and assuming that there is no initial loss to follow-up, so linking them to care once they diagnosed with TB and initiating treatment. And the second scenario, maxed out, does include TPT for both PLHIV and household contacts, but also we are maxing screening, but only 2 times a year. So assuming that South African adults would be screened 2 times a year, and also assume some targeted universal testing for household contacts, and also still assuming no initial loss to follow up between treatment, between diagnosis and treatment. And yes, and Lisa will go through the results. Thanks.
Thank you, everyone. Next slide, please. So I'll take you through the outcomes, and will be structured as follows. So I'll first take you through the impact these interventions and scenarios will have on reducing incidence and mortality. Then I'll take you through the budget impact over the next 5 years under the different scenarios. And then lastly, we'll talk about the cost effectiveness over the 20-year period. Next slide. So jumping straight in, when we're looking at specifically focusing on our NSP and MAX scenarios, we can see the tuberculosis incidence rates are expected to decrease under baseline anyway, so a slow decrease. Under the NSP scenario, however, you could see this slightly larger impact in the reduction in incidence over the next 20 years. And under the MAX scenarios, we see an even bigger impact. But as big as these impacts may seem, none of them actually reach the 80% reduction, the end TB targets of 80% reduction in TB incidence. Next slide. Mortality rates, we see a similar scenario, similar pattern. So we will see over the 20 years under baseline, we see a slow reduction in TB mortality. Under the NSP scenario, we see a reduction to around just around 90 deaths per 100,000, and then the MAX scenario 1 and 2 have larger impacts. Again, none of these actually reach the 90% reduction target, and probably won't for the next coming years, looking at the slope of the mortality rates. Next slide. This table just represents the TB incidence and mortality reductions by 2030. Again, trying to see how far do we get in terms of reaching the 80 and 90% targets for each of the scenarios. These end up around 40 and 50% under the MAX scenario 1 and 2, and under the NSP scenario, we can reduce the TB incidence by 35% and 40% under mortality. Next slide. This slide represents the impact of not the scenarios. So the scenarios are the package of interventions, but here we're looking at the individual interventions just to dive a bit deeper on how each of these impacts in terms of the incidence and mortality over the next 20 years. So you can see the biggest impact we will get on mortality would be from increasing expert testing at around a 10% reduction in in mortality and a 6% reduction in incidence, whereas the screening interventions for household contacts, PHC and IPT for household contacts reduces mortality by around 7%. All the other interventions have a 5% reduction or lower in terms of incidence over the next 20 years. Next slide. And then over, for the packaged scenarios, the NSP scenarios and our max 1 and 2 scenarios, you could see bigger impacts ranging from 10% to 23% impact on incidence between the NSP and scenario and the max 1 scenario, and a reduction in mortality from around 18% to 40% over the next 20 years. Next slide. So when we look at the impact of, these would be the impacts on the incidence and mortality, but how do these translate into key indicators in terms of resources that will be needed if we implement these scenarios? So looking at the number of screenings, this includes symptom screening and digital chest x-ray. Under our baseline, we're sitting at around, I think it's about 30 million screenings per year. It's relatively stable, doesn't really change over the coming 20 years. Under the NSP scenario, this increases slightly to around 50 million screenings. Under our max 1, 2, and 2 scenarios, which were designed to increase the screening, you can see these reach extremely high numbers of between 150 and around 300 million screenings per year. These are quite unrealistically high numbers to achieve. Next slide. In terms of clients initiated on TPT, at baseline, we're sitting at around, just under 400,000 clients on TPT. Under our NSP scenario, this just more than doubles at 800,000 clients on TPT. And our max 1 and 2 scenarios are sort of in between, with reaching and under our max 2 scenarios, we reach almost a maximum of 1.3 million, and then clients on TPT, and that tapers off as time progresses. Next slide. Clients tested with Expert Ultra. Under the baseline scenario, this is sitting around just under 4 million, between 3 and 4 million clients tested on Expert. Under our NSP scenario, we can, this more than doubles at around 6 to 8 million clients tested on Expert. And under our max 1 and 2 scenarios, these go up to 10 million clients and up to 14 million clients. And these possibly go way beyond the current capacity of expert testing that we can do in South Africa. Next slide. In terms of clients, number of clients treated, you can see under baseline, we're currently sitting at around, just over 200,000 drug-sensitive outpatient treatment. Under all our scenarios, NSP max 1 and max 2 scenarios, we see a huge initial jump in the number of outpatient treatments that we can expect in the initial year. This is largely due to the increased screening and improved loss to follow-up. But there's this initial investment in treatment, and then this declines quite sharply to a point where it reaches below the projected baseline level. And you can see that over the next 20 years, we will have less clients on drug-sensitive TB compared to what they would have been under the baseline scenario. Next slide. And just a quick comparison on drug-resistant treatment. We see a very similar pattern in that there's this initial increase in clients on drug-resistant treatment in the initial year, and then this declines, although it doesn't reach levels below baseline. But we're sitting around an expected 6,000 people on drug-resistant TB treatment, and that makes up about 3 to 4% of all cases in South Africa. Next slide. And what will this cost look like? So if we're looking over the next 5 years, our expected baseline cost was sitting around 3 billion rand per annum over the next 5 years. The biggest drivers of these costs, again, just to repeat, this is at baseline, so current trajectory if nothing changes. Our biggest drivers will be our expert testing at almost a third of the, or just over, a quarter of the cost of the TB program, and then our outpatient TB treatment for drug-sensitive TB will be also about a quarter of the cost of the TB program, and then our drug-resistant TB takes up about a fifth of the cost of the TB program. Next slide. Under the NSP scenario, where we're reaching our NSP targets, we can expect the cost of the TB program to reach between 4.4 and 4.7 billion rand per annum. The biggest drivers of these costs under this scenario would be TUTT for PL-HIV, which would take up 20% of the cost. Expert testing also would have a similar portion of the cost, and then our in and outpatient drug-sensitive and drug-resistant TB would take about 16% and 14% respectively of the total cost of the TB program. Next slide. Under our max scenario, our first max scenario, where we have around 4 adults screened per year. Again, this is screening heavy. We expect this to cost around 12 billion rand per year over the course of the next 5 years, with majority of the cost being driven by either door-to-door screening or expert ultra testing, and then smaller portions of the TB program being made up of the cost of DS drug-sensitive TB treatment, as well as drug-resistant TB treatment at 9% and 7%. Next slide. And then similarly, our max scenario also geared towards screening. This will cost slightly less at about, compared to the other max scenario, but around 8 billion rand per year, with most of the cost being driven by door-to-door screening at 35% and expert ultra testing at 28%. And again, our treatment of drug-sensitive TB and drug-resistant TB make up 13% and 10% of the cost. Next slide. And this is just to illustrate what this would cost. This is over the course of the next 5 years, but just to compare between baseline, the NSP, and the max 1 and max 2 scenarios, just to show you the differences between these over the course of the next 5 years. The baseline total cost would amount to around 14 billion rand for the 5-year period. Under the NSP scenario, this would be around 22 billion rand, and 60 billion and 40 billion respectively for max 1 and max 2 scenarios. Again, most of these costs driven by screening and expert testing. Next slide. So this is quite a busy slide, but just to orientate you what you're looking at. So we are focused now on the cost effectiveness of individual drugs as scaled up to the NSP targets. And we run these through the model, measure the impact over a 20-year period, as well as the cost over a 20-year period, and then compare the incremental cost to the impact. And this is our ISA value at the far right. So this is an incremental cost effectiveness ratio, and this is cost per life year saved. And we order this list as the most cost effective, so the lowest ISA value to the more higher ISA value. So this is the most cost effective to the least cost effective individual interventions. And you can see the top of the list are scaling up our expert ultra testing to 3.3 million tests. This is annual tests. And you can see this cost 900 rand per life year saved. Similarly cost effective is TB screening and general PHC. We see there's a little jump in the ISA value, so we go up to around 2,400 rand per life year saved, and this is for reducing the initial loss to follow-up, TB screening for household contacts, and TUTT for household contacts are all similarly cost effective. And then from there it becomes less cost, the interventions that are midway but becomes less cost effective are essentially TPT for household contacts of persons with TB, TB screening and PL-HIV on ART, TUTT for individuals with history of TB, and then it goes all the way down with, at the bottom, we've got digital chest X-ray, which was one of the least cost-effective interventions, and then TPT for PL-HIV. Next slide. This essentially looks at the same thing, cost effectiveness, but our scenario packages. So the NSP scenario, in comparison to all the other, the comparison to the Max 1 and Max 2 scenarios, our NSP scenario is the most cost-effective intervention at 8,855 Rand per life year saved, and it will increase our compared to our budget, it will increase the cost of the TB program will increase by around 78% compared to baseline, and it will save around have a 15% increase in life years saved over baseline. Our Max 2 scenario is our next most cost effective at 10,000 Rand per life year saved, but it adds substantially to the cost of the TB program at almost 180%. And then our Max 1 scenario is our least cost effective strategy in this compared to the other scenarios at around 16,000 Rand per life year saved, and again almost triples the cost of the TB program over baseline. Next slide. So there are several limitations to this analysis and things which we are considering in the next iteration of the model as well. So pediatric TB is not modeled dynamically, which means we've included the cost of TB treatment for children, but the transmission is not actively modeled in the Tembisa TB model for now. The cost of the interventions, the cost of interventions used to link diagnosed patients to treatment is not included. So we're only making assumptions about reducing loss to follow-up, but we don't have an actual intervention which does this, or the cost of that. And then the cost of treatment for side effects of TB treatment is not included. This will only increase the cost of the TB treatment and make those, make interventions linked to TB treatment less cost effective, essentially. We also did not report sex stratified TB trends or impacts of interventions by sex strata. So there are differences in TB incidence and mortality between men and women, and it's possible or highly likely that if we had interventions which were targeted specifically to different gender groups, that we could have a more efficient impact on the epidemic. Next slide. So conclusions on the preliminary findings, we found that our most cost-effective interventions were expert testing, screening at PHCs, improving linkage, and TUTT for household contacts. Our NSP scenario consisted of targets which were deemed realistic by the NTP, though it only achieves an incidence reduction of 35% and mortality reduction of 40% by 2030 compared to 2015. It will cost and it will increase the cost of the TB program by around 4.4 to 5 billion Rand per year during the NSP period. Our Max scenarios, they were designed to get closer to reaching our incidence and mortality targets. However, we found that they increase the screening and expert testing numbers to an unrealistically high level. And even then, it doesn't really impact on incidence and mortality all that much more than the NSP scenario, reducing it by 40 and 50% respectively. And again, this is short of the 80% and 90% targets, which we hope to reach. The total cost of the Max scenarios increases the program cost by around 7.5 to 10 billion Rand per year. Again, this implementation would be the bigger issue in terms of reaching the high screening and testing numbers. Next slide. So our next steps, Tembisa TB needs to be recalibrated to newer data, very, very recent data. We need to dynamically model pediatric TB in Tembisa so we can accurately represent that cohort. We also need to measure the impact of early treatment initiation on disease severity, and also look at producing provincial versions, probably in, this will probably come in 2024-25. The other next step that we're busy working on now is looking at how to optimize the interventions in Tembisa TB, including taking into account multiple constraints, such as not just the TB budget, but also healthcare workers needed to implement some of these interventions. and also looking at having multiple optimization targets, not just cost effectiveness, but also looking at optimizing for mortality and incidence impact. Thank you.
Thank you so much to our speaker. It is now time for our Q&A session. Please keep your questions coming in. I noticed that Gesina had already responded to a question. So Gesina, just for the benefit of others, perhaps who cannot see the Q&A box, could you please respond to the question again? The question was, what was the specific reason for using the Tembisa model for this project?
So thanks. I think that is a very valid question. There are a number of TB transmission models already available for South Africa that have been used in the past to answer questions about programming, target setting, but also the cost effectiveness of different interventions. So the question is completely warranted. Why do we need a new TB model for South Africa? There's really two thoughts here, one of which I put into the reply already. The one is that we know, given the huge impact of HIV interventions on TB incidence and mortality, we need a model that, for South Africa at least, represents both HIV and TB fully and dynamically, which means that we should be able to change something on the HIV side, for example, the uptake of HIV treatment specifically for different age and sex categories, and then see a resulting impact on TB mortality in the TB model. And that is, Tembisa is one of the, well, is the only model that I'm aware of that does that, that's already calibrated for South Africa. And it was built specifically with that intention, to be able to say something about TB while also representing fully the TB epidemic in people living with HIV. Of course, most people living with TB don't also live with HIV. So, you know, we have the large part of HIV negative TB cases in Tembisa TB as well. But so that's the one reason. The other one is that we want to basically bring this all together into a combined investment case for TB and HIV, where we are able to now, because the budget is in large parts shared between HIV and TB, say what's the best use of that combined budget across HIV and TB interventions, which is really the only way to fully answer that question of allocative efficiency. So how to most efficiently allocate that combined HIV, TB, and STI and, you know, additional services conditional grant. So that's our next step, hopefully coming up in the next year. There was another question, if I can just quickly continue, about the decrease in mortality, and perhaps the person who put the question in can come online either in the chat or I don't know, perhaps unmute. I don't know if that's possible, and give more specifics about exactly what decline in mortality the question is about.
They would not be able to expand other than in writing, Gesina.
Yeah.
Yes.
Okay, so we might have to unfortunately skip that question.
Okay, and we have another question for the team. The question is, what is being costed in TAT and how does it differ from GeneXpert testing?
Pudi, can you take that perhaps?
So for the expert testing, it's just the testing cost. But for the TAT intervention, it includes the staff involved, because the way it's implemented is to inquire about patients' history of risk group. So whether they are PLHIV or previous TB or household contacts. So those additional costs, I think the difference was like 266 to, and for experts itself, and for the TAT intervention, it's about 300 Rand or something.
Thank you so much, Mama Pudi. We have a comment here from Dr. Lucy saying they just want to send their praise of what you guys have accomplished and that it's so amazing to see the scale of analysis. and it makes her feel very excited about what can be achieved. Thank you for that. And we have our second last question, I think, which is the TUT household modeled from a cost point of view, household-based or clinic-based? In other words, where is the specimen taken and the result returned to?
Okay, if I can answer. So based on the studies that have done, sorry, can I?
Yes, go ahead.
Okay, so based on the empirical study, we are basing it as a PHC. So yeah, we probably are not including the linkage. Well, bringing the patients together. So the question, the patients go to the health facility and inquired whether they have household contact, and if they do, then they'll get them tested.
Okay, thank you for that, Mama Pudi. We have a question about the estimation of costs for door-to-door screening. Did you adjust the cost estimate for distance traveled or adjust at all for different rates of TB prevalence or population density in different places? A very loaded question.
This is a question that perhaps I can answer best because I oversaw the generation of the cost estimates. So we don't have basically a space matrix in our cost at all. So for none of these costs do we include the very variable cost of reaching communities and doing this costing. We worked off intervention that's already 10 years old, unfortunately, but is still, I think, fairly representative of how this household screening is being done. That was piloted by Orem back then. And that has a fairly, a completely constant assumption about how many, about the yield, as well as the distance traveled. I don't have those data off the top of my head. The costing itself was done by Don Mutswengi, so that might be worth looking up that paper if you would like more detail, or getting in contact with either of us three directly for those details. But granted, if we wanted to do this more justice, we could probably basically vary this cost slightly across different population groups and locales. Our next step with this whole project is to have Tembisa TB at least at the provincial level, and we could do an fairly easy adjustment where we basically vary this cost between urban and rural population groups, which is what we've done already on the side of the HIV testing, and that worked quite well. In order to represent that, of course, it's more expensive to reach it, in particular households or communities in rural areas from, just given the amount of traveling it takes.
Thank you, Gesina. We have a question, another one. Why do you think the MAC scenarios will achieve the targets for incidence and mortality reduction?
Will not achieve. Sorry.
Okay, yes, apologies. Why do you think, yes, apologies.
Will not achieve. So perhaps I can also quickly talk to that. I already privately replied to a similar question asking about what else do we need to do in the NTP to achieve those targets. So I think this is the modeler's most frustrating moment, and I'm really sorry if we shared some of that frustration with the rest of you. We know that given the current set of interventions and what we know about their effectiveness in reducing mortality and incidence, we cannot reach those targets by 2030, no matter how maximally we scale up every single of those interventions. And that's exactly what we tested in those two MAC scenarios, which is a situation where we basically need to, reconvene and say, are those targets realistic? They never are. We know they're always aspirational. It's always what we think we can achieve, plus some, additional amount, just so we can overreach a bit and fall short of it and at least get somewhere, and at least we started. So that's all good. And I think all of us in TB programming, HIV programming, are veterans of this kind of overreach that we do towards those aspirational targets. So that's all fine. It's just that in our models, more than actual implementation, often tells us something about the realism of the future. We can, into the future, not reach those targets by 2030. So we could either reduce them or we keep them as they are and kind of try to get as far as we can towards them. But there is exactly nothing we can tell you from the modeling that allows us to get to those targets. So it's not a question of additional money. It's not a question of better implementation. It's just that with the combination of interventions we have available at the moment, we cannot reach those targets. We can get quite far. We can, even those 24 or 40% reductions of incidence and mortality are fantastic achievements if we get going in time, but we can't, get to those 80 and 90% reduction targets. We will at some stage, way into the future, several decades. We've had that question as well. We can't say at the moment, but we could. It's virtually many decades into the future that we would get there. So unless we have new interventions that are also religiously and maximally scaled up, we cannot reduce mortality or incidence by 80 or 90%.
Thank you, Gesina. We're just a minute over time, and apologies for that. As Nolwazi Nkosi and the Secretariat would like to thank our speakers for their time and would like to thank those in attendance for the impressive turnout today. And just a reminder, if you would like to present on this monthly platform, kindly contact us at this email address, nkosi@tbthinktank.org, or alternatively reach out to anyone else within the Secretariat. And just a reminder of our upcoming webinar taking place on the 21st of August, same time, 12 noon. And our upcoming webinar is titled Reducing Initial Loss to Follow-up Among TB Patients in South Africa, Key Findings and Lessons Learned from the LinkedIn Study. And thanks again for your time. I think that is a wrap from us, and enjoy the rest of your Monday afternoon.